We appreciate the live streamers being quiet and listening, unlike the rowdy bunch. And this gets done at 11. 11:15. We got plenty of time. All right. Well, as you start making your way back, I'll give you a little bit of updates on the live stream. So we got Ireland that's represented. That'll make our social worker happy. All four corners of the United States, if you look at it that way, are represented, so that's good. Welcome back, all you guys on live stream. So we're going to finish this session focusing on some of the motor symptoms, and at the end of it, we'll have everyone come back up here, and you can turn your questions in, and we can go through some question and answer, which ends up being a lot more interesting. We're more interested in what you guys have to say rather than what we have to say. So get your questions down. All right. So in the vein of telling David Robertson stories, I'll tell you a story about him. We had a meeting about 8 years ago, and he had a comment that he told me that when he thinks about MSA, he thinks about it as an autonomic disorder. And I said, well, when I think about it as a motor disorder. And he said, well, there you go. That's an example of the different ways that this can present. And yesterday, if you were able to hear the story of Doug and Danny, I don't know if you were able to come to that, but you'll hear his story that his first symptoms were his inability to bounce a basketball. And then he went on to get more symptoms related to autonomic dysfunction. And so I'm a neurologist, and I take care of patients with motor symptoms predominantly. I'm what we call a movement disorder neurologist. And so patients will come to me complaining about usually not walking properly or not being able to manipulate things with their hands efficiently or not able to have the dexterity that they used to have. And so I'll look at MSA really from a motor-related disorder, but of course as a field we think of it as a kind of general brain-related issue. So what I'm going to do today is try and demystify a lot of these terms that get thrown around when we talk about motor symptoms and MSA. I'm going to make you all smarter than movement disorder neurologists. It's not very hard, but we can do it. All right? Does anyone know what this picture is? Oh, I heard someone online say it was the Wycliffe Bible. That's exactly right. So this guy translated the Bible from Latin into Old English in the 14th century, and it kind of made people able to read it more. And so hopefully, not to say that my work is as important as that fella, but as what we can do here is demystify some of the terms that you may hear when it comes from a neurologist who says things like, well, I think you have MSAP, or MSAC, or MSACP. And you're like, what is this guy talking about? What is this person talking about? So let's do a little bit of, anyone know what this is? There you go, brain. Well done. 5 points. Okay, so a brain, and the front part of this brain is to the, when you're looking at it, to the left, and the back part is looking to the right. The down part is below, and the up part is up. And you can see that there's two terms here, brainstem and cerebellum, and they're kind of conveniently indicated here. And those are two really important parts of the brain that get affected in MSA. And depending on how much it gets affected or where it starts or where it progresses, you'll have symptoms related to brainstem or cerebellar features. And so I'm going to try and tell you what they may look like, to give you the breadth of how dysfunction of the brainstem or dysfunction of the cerebellum could impact a person's life. All right, so here's you know what this is? It's an MRI. How many people have had an MRI here? A lot. I just went through a 1.5 hour one and then a 7 Tesla scan for research. It's pretty interesting. I'll tell you a funny story. So I was wearing a bow tie. I usually wear a bow tie. And I didn't take it off when I went into the MRI scanner. And I was lying there, and the technician pulled me out, and he said to me, hey, Dr. Claassen, I just wanted to ask you a quick question. Have you ever had an MRI scan before? I was like, yeah, I've had an MRI scan before. And he said, oh, okay. did anyone ever comment about your cerebellum? I was like, no one's ever commented on it. He's like, yeah, we can't find it. And I was like, really? What? How is that possible? Let me look at it. And so I looked at the cerebellum, which is right. Let's see if this pointer works. I think it's right down here. Right down here, the cerebellum right here, right? And it was gone. I looked at it. It wasn't there. And I was like, I am a freak of nature. And I realized that there's a little clip on the back of my bow tie, which was made of metal. And it created this artifact. You couldn't see my cerebellum. So, that's my story about the cerebellum. That poor technician, his heart was pounding. He thought that he had diagnosed this neurologist with this weird disorder. So it may be customary if you're a patient who has motor symptoms to get an MRI scan. And you wonder, why are we on an MRI scan? Well, it turns out that MRI scans can actually be sort of helpful in localizing these things that we call brainstem dysfunction or cerebellar dysfunction. And this is an example of one of those pictures where you can see this big old arrow here on the left. That's your brainstem. And you can see that there's sometimes in MSA that you can have this picture that looks like a crucifix through the brainstem. And that's an indication that some of those neuronal fibers and those neuronal cells are not working well enough, or they're degenerating, and they give this interesting picture like a crucifix through the brainstem. Other times you can see this part of the brainstem called the pons. We kind of talk about it looking like a hummingbird sometimes in other disorders, but that would be the beak of the hummingbird and the head and the wings. And that's the pons, the wings part. That can actually be also atrophied or shrunken down, and that can also be flattened, and that can be also indicative of things like MSA. And then the cerebellum. This is my cerebellum, I think. I found it. Yeah, found it. But you can see that in this person here, the cerebellum has what we call atrophy. Do you see that? You see how this is a little different from this one? There's a little bit more blackness around it. So the point of it is that when you have MSA, you can have dysfunction of the brainstem, dysfunction of the cerebellum, and that can create a picture, a movement picture that differs from patient to patient. But the way it presents actually is kind of important because it will help us a little bit with treatment and also with things to look out for. All right, so I've told you about the cerebellum and I've told you about the brainstem, and now I'm going to give you two more terms that are going to make you smarter than your neurologist. Parkinsonism and ataxia. Anyone heard those terms before? Or is this the first time? We've got a smart audience. And be careful with what I say here. All right, so why do we use the term Parkinsonism? It's a funny term, isn't it? Well, it probably comes from this essay that was a long time written ago by this fellow named James Parkinson. And he wrote this essay that's called the shaking palsy. And if you think about it, it's a funny term because a palsy implies a weakness, and then you have the shaking weakness. It's kind of this contradiction of terms, right? But he had noticed these patients that had this tremor, but were also a little stiff and slow and weak. And he put them together in a case series, and that's where we get the term Parkinson's Disease from that seminal paper. But it does highlight some of the quite unusual manifestations of motor symptoms that we call Parkinsonism. And so these symptoms can range from stiffness or rigidity, slowness of movement. The fancy term we use for that is bradykinesia. It's not a term you probably use very often at breakfast, but it's a term that neurologists will talk about, maybe. Slowness of movement, slow kinesia movement. The resting tremor, so a lot of times at rest, a person will have a little bit of a tremor. Like it kind of looks like back and forth hand tremor. And so your neurologist will look at you carefully, maybe get you to distract. He'll probably say something like, well, what I do with my patients, I say, I want you to give me the months of the year backwards, starting with December. And the patient's looking at me, are you serious? And I'm not really listening to them. I'm just getting them distracted, and I'm going to watch their hand. And if their hand starts tremoring, that's indicative of this resting tremor phenomenon. Gait instability. Gait, a fancy word for how we walk, how we control our walking. And so you'll watch a patient walk, and you'll get them out of the chair, and you'll watch them how they get out of the chair. Do they get out by needing assistance? Do they get out by their own volition? And you watch them walk down a hallway. You can learn a lot about a person's brain by watching them walk. And so we spend a lot of time working with our patients. And we talk about restricted movements. So when you're just not able to do things as big and as fluid as you used to. And those are all features of Parkinsonism. And so you can imagine that a person could manifest with very different symptoms but still have Parkinsonism, right? So you may not be someone that has a lot of tremor, but you got a lot of rigidity. Or you may be someone that has a lot of tremor, but not a lot of rigidity. And so part of what we do as neurologists is trying to put all these clinical observations together, along with your history, and build a localization picture as to where in the brain is this disease affecting. And again, we're looking at the brainstem and the cerebellum, generally speaking, when we talk about MSA. I'm not making any offense to my autonomic colleagues who care about other parts, but as movement people, that's what we focus on, those two things. All right, here's a picture of a man. So what do you think this picture is depicting? Balance problems? Right, and so you can see that perhaps if you looked at this fella walking, you would notice that his gait is a little bit wide-based, so his feet are a little bit wider than you typically would see someone who's standing kind of at attention. And you can see this picture is illustrating someone that may have a little bit of difficulty walking. So what kind of gait do you think this would be? Do you think it'd be, what's that? Ataxic, well done. So this is another example of how gait can be different because of a different localization. So in these cases, we talk about ataxic gait. Remember I told you ataxic refers to cerebellar. And so an ataxic gait is very different from a Parkinson's gait. So a Parkinson's gait typically looks like, I thought I had a picture, but I didn't. Kind of a stoop posture, and your steps may be a little short and shuffled. I'm imitating it for you if you can't see me. But I'm imitating that my feet are not moving very big. They're kind of shuffling, right? Versus an ataxic gait where a person's got a little bit of a wide base gait, and they're having a hard time getting their legs to move in a fluid manner. So it may be that when your neurologist sees you, and he gets you, I'm assuming all neurologists are male, of course that's not the case. Just excuse my vernacular. But when they get you to do your tandem, have you ever seen that talk about doing the state trooper walk? That's what I tell my patients to do. Can you do the state trooper walk? And they usually comment, oh, if I was pulled over, I wouldn't pass it. But that's an example of how we're really trying to stimulate that cerebellum. Because when you do that, that's a cerebellar function. So we're really trying to hone in on that cerebellar pathway. So how you walk and how you are able to control your movements really helps us localize where the pathology is. Some other comments of this term ataxia, and it sounds like you guys are finally remembering that ataxia means cerebellar dysfunction. What else could it be aside from gait? It could be your speech. So your cerebellum regulates a lot of movements, including your speech. And so if you've ever heard someone who's had a little bit too much to drink and they talk a little slow like that, that's a cerebellum dysfunction, right? So a lot of patients will come in and their spouse will say, you know, he started to, I just can't understand him. I have to ask him to repeat myself. And you always ask the spouse, well, have you been checked for hearing? And they say yes, because that's usually one of the cases that a lot of my male caregivers say, I can't hear my wife, and the wife says, he's never heard me for the last 30 years. But that's another issue. But we talk about how a person speaks. And if they talk a little bit like this, that's sometimes indicative of this cerebellar dysfunction that's going on. Also, Parkinsonism can affect your speech. It can be a little softer. And you talk a little quieter like that. And so we have to figure out which is the speech problem. What is it related to? Is it brainstem or cerebellar or both? We talk about the different type of tremor when it relates to cerebellar dysfunction. And this might confuse you, but just bear with me. So I told you that in Parkinson's we get the rest tremor, right? When I get you to do the months of the year backwards, your hand starts tremoring. Well, with the cerebellar tremors, it's an action tremor. So when a person goes to make a movement, for instance, I'm going to pick up the peas with my spoon and bring them to my mouth, the tremor gets worse. And that's a cerebellar tremor. It's different from a Parkinson's tremor. That can be really frustrating if you're trying to button your buttons or tie your shoes or lift something up. And so your neurologist will ask you, put your arms out, hold them there. If you do that and all of a sudden you start doing this kind of thing, that's a cerebellar outflow tremor that we talk about. They'll make you point your finger to your nose and to their finger. And if you notice that there's a little bit of difficulty doing that, that's a cerebellar outflow tremor. So you can see it can get a little bit complicated in terms of which one's causing what. Not all tremor is the same. Not all gait problems are the same. Not all speech problems are the same. But what you got to figure out as a neurologist and as a caregiver and as a patient is what's the main cause of it. Because it probably will matter in terms of what kind of therapies that we go for, in terms of physical therapy, occupational therapy. I'll give you an example of that a little later. And also what kind of potential treatments may improve it. The other thing we think of, the difference between ataxia and Parkinson's, you remember I told you Parkinsonism is restricted movement? A lot of times with ataxia we have exaggerated, uncontrolled movement. That's an example of how there's differences. And the key point that I want you to remember when we talk about MSA is that it doesn't have to be the same thing throughout the course of your illness. It can change. In fact, most people have different types of movement problems throughout the course of MSA. You may start with mostly Parkinson's symptoms, but over time you may get more cerebellar symptoms, and that's the way the disease goes. And people are different in terms of what they start with and what they end with. So making sure you know the difference between the two can actually help you kind of interpret what's the issues going on here, how do we address this, and how do we proactively prepare for what's coming next. Just a couple other things that I mentioned for Parkinsonism that we've talked about. We've talked about evidence in Parkinson's gait, ataxic gait, Parkinsons Dysarthria. The fancy term we use is hypokinetic dysarthria for Parkinson's dysarthria, how you speak. Ataxic dysarthria, those are the two things. Limb ataxia, I illustrated with that. And then the other thing that can happen with cerebellar dysfunction is your eye movements may not work as well as they used to. And so what your neurologist will do is they'll say, okay, look over here, follow my finger with your eyes, and you may see this kind of jerkiness with the eye movements, so that when you're looking over to the right or to the left, your eyes aren't obeying you like they used to. They may be difficult to focus. And so it's not uncommon for some of our patients to tell us, you know, I'm trying to read my book and it's just not working well, or I'm trying to navigate how to get through the house and I seem to be bumping into walls, or I have a hard time kind of figuring out depth perception. And that may be related to that cerebellum causing problems with the way you can volitionally control your eye movements. So here is your quiz. If you fail your quiz, I'm going to make you retake the course. There will be no bonus points. All right, so here's a gentleman. Tell me what his gait looks like. White-spaced? Yeah? Leaning? He's leaning a little bit. Good. It brings up the next session. What's that? Ataxic? Exactly right. So this gentleman has more of an ataxic gait. He came to me with complaints of falling down. And there's Jesse. There you go. So what did I just get him to do? The state trooper walk. See, we're from Tennessee, everybody. This is what we talk about. Tandem Gait, that's garbage. This is the state trooper walk. And he has a real hard time with that, right? So which way do you think this chap falls down when he falls? Side? Side, maybe? Oh, watch this. It's a little unsteady. So he's actually falling backwards a lot. So this is a resident. There it is. See that? So what do you think would cause this gentleman to have a hard time with his day? Going to the bathroom, maybe? This is where he fell. He fell in the bathroom. He got up, out of bed, a little lightheaded, as you can have with autonomic symptoms. He walked to the bathroom, tried to turn around, fell backwards, hit his head against the bathtub. Right? Falling backwards is one of the biggest problems that we have in MSA. I would say. When I hear a patient that comes and says, I'm falling a lot, and I first ask them, well, which way do you fall? And they say backwards, my red flag goes up. No, this could be one of those MSA presentations. And so what we work with patients who are falling like this is we really get our physical therapists on board early and quickly. And what we say to them is, we think this gentleman has a difficulty with his cerebellum, coordinating his posture, and we'd like you to help us with gait safety. We want you to do 3 things. We want you to put in some rehab to try and improve his balance. We want you to recommend what kind of walking assisted device that he could use so that he doesn't have to rely just on his cerebellum to keep him up, but sometimes he might need a walker or something like that. And then the third thing is that we'd like you to do a home safety assessment. We'd like you to go to the house and look around at his floor, his rugs, his bathroom. Are there any things that we can do to reduce his likelihood for falling? Because we don't want a person to fall, hit their head against the bathtub, have a subdural hematoma, a.k.a. a brain bleed. And so that's some examples of what we do for our... Okay, so let's see if this one works. See, I'm looking at his brain there. So what am I getting to do here? Having fingers? Good. Why am I doing that? What's that? Rapid alternating movements. And which part of the brain am I assessing here? Both is okay. The cerebellum and brainstem. Both of them. I'm just trying to make sure you listen to me. All right. So what am I doing here? Foot tap. We're looking for those alternating movements. Are they fluid? Are they restricted movement? Or are they exaggerated movement? You can see how they're kind of irregular. He's got some asymmetry. Well, nice, astute looking. I'm looking at his heel taps. Are they nice and fluid? So one of the funny things about some of my patients is they'll tell me when they're tapping along to music, they're not able to do it well. A lot of people, when they go to church and they clap with the music, they find that they're not clapping in rhythm. That's an ataxic issue because they're not able to keep that internal rhythm. And this, I believe in this case, this is one of those cases where he was able to do that. And here's an example of the eye movements issue. I don't know if you can see this properly, but what I'm getting him to do is I'm saying, look to the left, keep following my hands, look to the right. If you can see it, he had a little what we call nystagmus. His eyes were kind of going this way. And there's my finger in case you wanted to look at it. I think I did it again here a little better. Oops. So we put this gentleman on a therapy for his movements, and what's interesting, and one of the things that I'll talk about a little later but want to make an emphasis is that sometimes therapies can be helpful for gait. And this chap got put on a medication to improve his low blood pressure, which was a big problem, and he noticed that his gait got a little better. And I would say that while I'm trying to make your life really simple and talk about cerebellum and brainstem and those two things and how they can affect movement, I don't want you to forget that the autonomic nervous system really can help you with movement. And this guy, he's still ataxic, but he noticed that when we put him on his medication for his autonomic problems and he came back to see us, he had noticed a reduction in falls and an improved walking, and that could have been a result of the physical therapy, could have been a result of the medication, could have resolved the safety controls, but ultimately he had noticed an improved response. And you can still see he's got that postural reflexes. Okay, they're absent. Okay, so that's a brief overview of the difference between Parkinsonism and ataxia. Now I'm going to talk about some other motor symptoms that you may find that you don't really think of as motor symptoms but may come up, not in everyone. One of them is this term called camptocormia, and that's a fancy term that probably came back from, I think it was the 1930s, I believe. Dr. Kaufman could probably tell me that. He's there. 30s? This is about 30s post-war. So these folks would have this kind of, you can see this flexed posture at the waist. And that can be really frustrating because you can't volitionally keep up, and it's just part of the way the disease affects the normal posture of the body, and that's one of the features you can see. This is called Pisa Syndrome. Someone mentioned earlier that this gentleman seemed to lean to one way. You know why we call it Pisa Syndrome. There's a picture of it, right? The leaning tower of Pisa. So a lot of our patients will kind of lean to one side, and it's part of their MSA affecting the way their brain controls their posture. And so you can imagine that like this picture here, this gentleman's kind of going to the side, and you can imagine how that may cause some gait abnormalities or some gait difficulties. Another term we talk about is the difference between anticollis and retrocollis, and this is basically collis to the head, retro backwards, anti forward. And depending on who you talk to, it turns out that probably a lot of patients with MSA will probably have this kind of anterocollis dysfunction. They'll kind of lean forward. And we're not sure why that's the case. It probably has to do with these muscles in the neck called the strap muscles, and they're kind of dystonic, means they just kind of restrict all the time without you wanting them to. You kind of give this look, and sometimes in other diseases you get this retrocollis where people go backwards, and so you can imagine that can be challenging for a person who's trying to walk, trying to navigate around the house, trying to look at things. All right, so here's your part 2 quiz. What's number A? Camptocormia. Good. Good. See, I'm going to make you guys smarter than neurologists. It's not that hard. B? Anterocollis. Yep. C? And D? Pisa Syndrome. See, there you go. So and that's what we do. See, neurologists are just people that look at things and describe them. That's movement disorder people. Another thing your doctor may do is do reflexes, and this one always surprises people. Why do I bother doing this? Why are you scratching the bottom of my foot? You are just torturing me. I usually say when I do this will be the worst thing I do to you all day long. I scratch the bottom of the foot. But we actually look for reflexes, and it turns out that you've got this natural reflex is when you just scrape the bottom of the foot, your toes typically go down. And when they go up, we call that the Babinski sign. And so a lot of our times in our early cases where we're not sure if this is Parkinson's disease or MSA, you sometimes get a little clue as to the reflexes. And so your doctor should, scrape the bottom of your foot. Turns out that infants, their toes go up. And my wife really got upset with me because every day I would check the Babinski of my kids to see when it would go down. But it's not supposed to go up. And so that's another little of these motor signs that you may find that makes you say, you know what, this doesn't look like Parkinson's disease. This may be multiple systems atrophy. Okay, so when do these symptoms start? That's a big question I get. I'll say generally speaking, most MSA patients, they first develop their symptoms around 55. And why do I say that? It's because generally speaking in Parkinson's clinic, they tend to be a little older. So what we look for is the age of onset, the type of motor symptoms when they start. That kind of matters in terms of coming to a diagnosis. And as we said before, what does it come with? If your person's got like an erectile dysfunction that's never happened, or urinary problems, or do sweating, constipation. Some of my female patients note inability to have to climax during sex. That's a big symptom for them, and that's another a big change in their life. And so we kind of look at the whole history, not only just the motor symptoms, but also the history of the patient's symptoms to come up with a diagnosis. Generally speaking, if you look at an MSA cerebellar patient, that's what these terms mean when you hear these terms MSA P or C. A patient that presents with mostly ataxic problems, by about 5 years they'll start getting Parkinsonism. And that just goes to show that it may start in the cerebellar-related pathways, and over time it starts to affect those more brainstem Parkinson's pathways. All right, so now I'm going to talk about movements that happen when you sleep. Why is he talking about my sleep? All right, so I think the next one's a video. Okay, so this is a chap who's in what's called a sleep study. And he's sleeping, and he's sleeping, and he's sleeping, and all of a sudden he does this. Ever seen this before? It's usually the spouse who says to me, we sleep in separate beds ever since he started wailing on me. I hear an amen over there. There we go. Does anyone know what this is called? REM behavior disorder. There you go. Good job. So REM behavior disorder it probably is another one of these atypical movements that happen in sleep, and it's related to how your brainstem controls and regulates your sleep pattern. And it turns out that it could probably be one of the earliest symptoms of MSA and related diagnoses. And so what happens is when you go into REM sleep, your brain basically turns off all your muscles and basically says, you know what, we're going to dream about hitting a home run in the World Series, but we're not actually going to swing. And when that brainstem gets affected such that you can't turn your muscles off, you start acting out your dreams in REM sleep. And what's fascinating about these is that these dreams are usually about animals in the room or people chasing you or attacking you and you're trying to get away from them. And it can be very disconcerting, especially to the spouse who's lying in the bed and all of a sudden gets wailed on by a partner and he wakes up and says, what? What's going on? Why are you upset with me? So it's really important to talk about these symptoms with your neurologist or your doctor, because it turns out that these symptoms are movements when you sleep and they shouldn't be happening, and we can actually, with a decent ability, treat them. So we typically use things like melatonin, which is an over-the-counter supplement to improve your ability to sleep. It turns off these movements sometimes. Other medicines like clonazepam, I don't know if you've heard of that one, that can use, and then there's other ones that we can use sometimes in more extreme cases like quetiapine or Seroquel. But these movements are really important because they're related to MSA. And so your doctor should talk to you about not just your movements when you're walking or when you're picking up things, but also your movements when you're asleep. The other one is that we talk about with our MSA patients is laryngeal strider. And so what I advise my caregivers to do is really listen to the way their loved one sleeps at night. So if you hear this, that's stridor. You know, I have kids, and they get, that croup. It's that kind of sound. You know what it sounds like if you've had kids. That croup comes around this time of the year. I can't wait. It's going to be great. But it's actually really important to listen to your loved one, but with this sound, because this can be a sign of impending oxygen dysfunction. And it's something that we really act quickly on. So if I have a patient that's got this sound, I call my sleep colleague and I say, I need a sleep study, not next month, but next week. I need to get this done now, because I want to make sure they don't close their airway off and die from it. And so sometimes a lot of our patients who have this symptom will have these tracheostomies. They put this little hole on there to try and reduce the likelihood of this happening. Some of you may have experienced that personally, and that can really save your life. So that's the other thing I'll comment about sleep, is that just remember, listen to how they sleep. Do they stop? Do they hold their breath? Do they have that stridor? Because it's very important. All right. So as we wrap up here, I'm going to do some more comments about gait, because I know that that was what I was told I had to talk about. Well, I told myself I'd talk about it. But talk about what this, some other comments. So the big issue I want to make sure is that you don't think about these things as two separate clinical issues. We really want to be comprehensive in how we think about symptoms in MSA. So a question like, is my falls related to blood pressure, is actually really important. So you can notice, when is the person falling? What is this clinical context? If they're falling a lot, it's probably not a bad idea to check their blood pressure sitting and standing up. At least that. You can do lying down as well. But at least get us some positional sense for how the blood pressure is changing, because it really does dictate your treatment. Are the legs giving out? So some people don't fall just from balance issues, but their legs seem to buckle or kind of give out. That's sometimes a symptom that there may be autonomic issues driving. And then, as I said, which way does a person fall? Really being specific when you talk to your neurologist. He tends to be falling forward. That gives you some clues to potentially what therapies may be useful in terms of walker and things like that. Big question I get is levodopa. Anyone know what levodopa is? Yeah, dopamine, right? We use it for Parkinsons disease a lot. And there's a lot of comments about levodopa. And in fact, I was sent an email recently. I haven't responded, so if you're looking on Facebook Live, I promise I'll get back to your email. But a very long email about whether or not levodopa is toxic to the brain, or whether or not it can accelerate symptoms like MSA and things like that. And so I will say that it's a very reasonable therapy if a person's having symptoms related to Parkinsonism. So if you're a patient that's suffering from slowness of movement or tremor, or you're walking from slowness of movement, it's very reasonable to try Levodopa. And the key point is that if you have MSA, Levodopa may work for you. It's not just because you get diagnosed with MSA and not Parkinson's that, well, Levodopa, I'm going to not use it. It actually may be therapeutically beneficial to you. How do I know it's working? What I usually tell my patients to do is it's okay to stop it. You can stop it for a day or so, and you can ask the question, do my symptoms get worse when I'm not on the medication? It's a very easy way to figure out if my Levodopa is working. It's probably one of the most common questions I get from patients with MSA is like, should I be on Sinemet? And so what I tell people to do is take notes. You know, when we start the medicine, we're going to pick a couple things that we think it's going to improve. I may say, let's pick these two things. Bradykinesia, which means slowness of movement. There you go. And let's say walking stride length. And we're going to look at those two things. We're going to say, once we start this medicine, we're going to titrate you up over 4 weeks. And you're going to tell me at 4 weeks if those two things have gotten better. In fact, what I'm going to do is I'm going to take a video today in the clinic. When you come back in 4 weeks, we'll look at that video together and we'll see whether or not you've improved. So follow the symptoms when we start a therapy, because you should be able to see if they work. And the key part about Levodopa, which I explain to my patients, is that it's not going to treat the cerebellar symptoms. So if you've got an ataxic gait or ataxic dysarthria, Levodopa isn't going to help that. It's going to help the Parkinsonism symptoms. So know the symptoms that you think you're going to get improvement with the therapy, and that's really key when you start medications. All right, so in summary, we've talked about some very diverse movements in MSA, all the way from dysarthria to bradykinesia to gait to movements during sleep. These movements and these symptoms will change over time. This is a progressive disease that will change over time. And so it's important for you as a caregiver and as a patient to be aware of where these symptoms localize to, what part of the brain that causes it, and also what kind of symptoms to potentially expect over the course of the disease. Like generally speaking, when we talk about motor symptoms, we talk about Parkinsonism versus ataxia. But I do want to emphasize that how we sleep is very important, especially the movements you have at sleep at night. Okay? So that's my talk. Thank you for listening. Now, write your questions down, and we will go around and pick them up, and I'll have the other folks come up here. Amanda and Cindy, if she's here, they are. And we can conveniently sit at the front here, and I will take your questions while we're picking them up. Any dying questions, any impulsive questions you're dying to ask me? Any dying vocal questions? Go ahead.
Over time. Sometimes do you get the symptoms for a couple months and then they go away?
So say one more time.
So you talked about symptoms changing over time.
Yep.
Sometimes do you, for example, like might have tremor type symptoms for a couple months and then they go away?
Yeah.
I mean, do they not only come and change, but also sometimes go away?
Yeah, so it's a good. So I would say the answer to that is certainly, because the brain does funny things, you know, and it's not unusual to have a symptom that you struggle with one day and then the next day you don't have it. We have fluctuations. It's very common in alpha-synuclein related issues to have fluctuations, both in other diseases like Lewy body disease. You talk about fluctuations in cognition. It's just, yeah. So I will say one more point is that it really matters to look at generally the progress over a long time. That's very important for a clinician. Yeah. Yeah, cerebral colic. All right, I'll come back to you once we get through these ones. All right, do you guys have one that you're dying to answer? You're happy to stand up. You got one? Was it working? You can use this if that's not working.
Well, I have one question here. Is Norvera better than atomoxetine? And which one would you recommend? So that's a hard question to answer. We really didn't do a comparison side by side with Norvera, which is droxidopa, with atomoxetine. So a lot of what we do is it's difficult to predict which patient is going to respond to which medication, especially in the early phases where sometimes the patient just presents with significant drop in blood pressure. One of the studies that we're trying to, one of the data that we're trying to get together is to see if there are any predictors of response. And Horacio, you presented that data in the AAN meeting that showed that maybe the norepinephrine levels can help us to predict that, because in patients with a normal sympathetic nerve, usually it's normal or elevated. So how long atomoxetine peaks? Well, the majority of the studies that we have done, we measure the blood pressure effect at 60 minutes. And based on, the properties of this particular medication, usually lasts between 4 to 5 hours. And the last question here is whether it causes constipation. And the label of atomoxetine indicates that in some patients may cause constipation. However, the doses that we use are the very small doses that we use in children.
Well, I told you the right questions, and you guys went to town. I hope I can get through them all. All right, I'm going to deal first one with the live stream questions. Thank you for your questions. The first one was, for Pisa Syndrome, is leaning to the left a common symptom? The answer, I think, to that one is Pisa Syndrome, it doesn't matter which way you lean. It's just that if you lean. And that's what we're looking at. If a patient's walking, they have a propensity to go to one side. It could be the left. It could be the right. And then the second question was, do patients with MSAC usually develop MSAP as well? And the answer, I'd say, is certainly. It's certainly common. You can go from one way to another. You may start with Parkinsonism and go to cerebellar. You may go with cerebellar and get more Parkinson's. They are fluid diagnoses, but generally speaking, the purpose of the classification is to try and conveniently categorize the predominant motor symptom that a person's having. Do you guys have one, or you want me to keep going? Looks like Amanda's got her cards all in a row. I'm going to keep going. Is the progression of symptoms predictable? Great question. I'm hoping that with our natural history study that Dr. Kaufman talked about yesterday, that we'll get a really nice answer to the predictable course of disease. Certainly in my clinical experience, one of the predictable changes is the progression of motor symptoms, in that if you start out with cerebellar, you may get more Parkinsonism. If you start with Parkinsonism, you may get more cerebellar. And so I would say that generally speaking, we talk about that predictable changes. In terms of how REM sleep behavior interacts with that, generally speaking, we find that REM sleep behavior can get better over time with the right therapy. But we often see some people present very early with it, and some people present later with it. And so it kind of can vary, much like any disease can. You can have different symptoms that start in different people, but hopefully with our big natural history study, we'll be able to get some nice data on how these things progress over time. And if you're not involved in it, sign up. We'd love to have you. Want to keep going?
Sure.
Go on.
We have several. I was trying to...
I wish I could take a photo for everyone to see Amanda's.
Well, I'll answer. There's two questions that are somewhat related. One was, and I don't know if you want me to take it or you, basically, can you see ALS symptoms in MSA patients, like breathing issues, Strider? And there was another question about MS and MSA. And I will say that because all these disorders affect the brain, and MS is a disorder that affects the brain in multiple different areas, So it can clearly affect the cerebellum. It can clearly affect different parts of the brainstem. And so some patients with MS can get autonomic problems. Some patients with MS can get significant ataxia. So that's when it comes down to having a doctor who can really be able to tell the difference between these two disorders, because the pace and the tempo and the way people present is different. And there's a lot of overlap. So can you see ALS symptoms in MSA? It's rare, but there are some MSA patients who can get what we call motor neuron degeneration, where they can get weakness like in ALS. The other problem is they can also get, so the stridor and breathing issues in MSA are a little different than what you get in ALS. So in ALS, the problem is the diaphragm gets very weak, whereas in MSA, the diaphragm is working, it's just not coordinated properly, and so it's not getting the messages correctly. And so even though you may end up using a ventilator and using the same things, it's from two different reasons. So that's what makes it somewhat complicated. And some of the things that we use, for example, since I also work in the ALS clinic, and I also work in the muscular dystrophy clinic, one of the things that we often refer, patients for is, power wheelchairs and getting evaluated for, appropriate mobility devices, so, trying to make sure people are on track to the right thing, because, regardless of the cause, sometimes the treatment is the same. So hopefully that answers. And then...
Okay, I have a couple of questions. And one of them is, will atomoxetine be helpful for an MSA patient who is unable to stand or use her arms? We feel that, at least in this preliminary data that I show that, the standing blood pressure increases and some of the symptoms increases, and we hope that with this long-term study we can address specifically that question. Now, about the use of the arms, if the problems occur when the patient stands up, that's probably more related to a blood pressure problem. Maybe if we can, fix, the drop in blood pressure by giving different medication, that can get better. Now, the ability to use the arms, in patients with MSA could be just related to the movement, disorder problem. Should I continue?
Yeah, sure.
Okay.
Yeah.
So the other question is, what are the most recent studies and how do we find trials to participate in? And that's a very important question, because right now the NIH has this website called clinicaltrials.gov, and then these are publicly available. You can log into that particular website, search for the disease, and they will pull up all the studies that, and whether they are enrolling, they are completing, and the contact information. So both the studies, the study with atomoxetine and the study, that I show with a particular molecule, the T9, so it's already available, and it shows the status of recruitment. And you can also, look at specific websites to know, what are the results of these studies, because right now every investigator that is funded by federal agents, we need to include those results as well.
Good. So I've got a couple live stream questions that I'm going to bring up. Thanks for asking them. The first one, I love this question. Does deep brain stimulation help MSAP symptoms? Great question, because as you know, for a lot of patients with Parkinson's disease, deep brain stimulation can offer a lot of potential benefits. It can reduce the tremor that a person's having. It can reduce the amount of medications that a person needs to get through their days. Great question. So I would say that generally speaking, and I'm talking generally, okay, we don't generally try and get patients with MSA into deep brain stimulation, because some of the early studies suggested that when you do deep brain stimulation in some MSA patients, you get more rapid declines in function. Now, there are a number of exceptions to that generally statement. And in fact, we have a couple cases now, I think we've got 4 cases now where we've done deep brain stimulation in different MSA patients. And for those patients, they were having either such severe tremor that it was impacting their quality of life and no medications were having it, or they were having such adverse response to levodopa and yet they needed it that we had to give deep brain stimulation to try and reduce some of those adverse effects as dyskinesias. That's when you kind of, like the Michael J. Fox video where he's moving around a lot. So I would say, so when you're deciding to do deep brain stimulation and you have MSA, it is a very thoughtful decision that you have to really consider the potential risks of your symptoms progressing a lot quicker and the potential benefit that you may get some improvements. And there are cases where it does work, but generally speaking, we try and dissuade folks from getting it done. Another question from the live stream: does hot breast bun sign always show in an MRI of an MSA patient? And a great question. I would say no. It doesn't always show. Sometimes it does. Sometimes it doesn't. There are some other MRI signs that I didn't get into too much detail about today, but there are other MRI features that can happen in some MSA patients. Sometimes what we call the putamen, that's another part of the brain that's deep in the brain. Sometimes the rim of the putamen can change, and so there are other pictures that can happen in an MSA patient. But generally speaking, we do get MRIs in patients, at least at the initial diagnosis. We generally don't get MRIs over time. That is, every time we see you, we don't get an MRI scan. But it can aid, early on especially, in trying to figure out, is this Parkinson's disease or is it something else, like MSA? And that leads me to the third question that came, which was, can you explain to me the difference between PSP and MSA? Haven't talked about PSP today. All these three-letter words. PSP stands for progressive supranuclear palsy, and it's a cousin to Parkinson's and MSA from the standpoint that you can have gait instability with PSP, you can fall with PSP, you can have eye movement problems with PSP. So we would generally classify these kind of pathologically as very different. When we think about PSP, we think of this protein called tau that accumulates. When we think about MSA and Parkinson's, we think about this protein called alpha-synuclein. The main clinical difference that we find is that a lot of PSP patients have a lot more cognitive issues. They're a lot more impulsive. They have a lot more gait issues, and their eye movements tend to be a lot more affected. So they look very different, and their speech even sounds a little different. They get a little bit of a spastic dysarthria, which means they kind of get a tight voice and high-pitched tight voice. So they're very different, and but it's a good question because it's someone who's astute to the different types of Parkinsonism that a person can have.
Okay, so one question was, lots of talk about neurogenic bladder being a problem. Is it also common in the colon, causing things like fecal incontinence? If so, then do the same people have neurogenic bladder, have neurogenic colon? So yes, so we don't really talk about a neurogenic colon per se, but the gut is affected by the autonomic system, which is why we were talking about constipation. The constipation is most common, but some people can get diarrhea. Some people can get fecal incontinence. Some people can have problems with leaking if they have a lot of constipation, but they still get some leakage around it. So, which can be very messy. And so yes, basically, yes, the answer is yes, you can get both of them, and kind of goes back to trying to figure out which problem is impacting you more, and I did not mean that literally. And trying to figure out what the best medicine to undo it would be, as far as would it make sense to change your diet, what does it make sense to add something to a stimulant to make you go, is there too much stimulation, so trying to regulate that can be just as difficult as the bladder. And then I have lost my sense of smell but can still taste, and I no longer sweat. So loss of sense of smell, interestingly, doesn't happen in MSA as much as it does in Parkinson's disease, but can still happen. The no longer sweating is very common because, again, those nerves that go to the sweat gland get impacted too. And unfortunately then, sweating is your way of basically controlling your body temperature, so when you can't sweat, then if you go out in a hot environment, you have no way of getting rid of that body heat. and that can be very difficult. And so then that often restricts what people can do, where they can go. We often recommend, some people actually get a cooling vest that they wear. I often recommend that they bring them a spray bottle and spritz themselves with water, because that's essentially what sweat is doing, is that what that water does is it basically brings the heat to the surface, allows it to evaporate off. And so if you spritz yourself with water, that can give you a little bit of the same effect. But a lot of times, sometimes unfortunately, it has to do with basically being very cognitive of the fact that you're not going to be able to handle the heat as well, and avoiding situations where you're going to be, out in the sun without any cover, or without any way of getting away from the heat.
Spritzing bottle with a fan on it?
Yeah, no, that's the best, is if you have the spritzing bottle with the fan, that's much better.
There is one question about repurposing drugs, and I think that's an important question. So the process of approval for a drug sometimes can take years. So repurposing of a specific drug that can decrease the length of time for a particular drug to be approved. And the reason is because this drug is already approved for a different indication, so we have data on safety. So and that can streamline the process. But to repurpose a medication, you need to learn about how the disease impacts several areas, particularly in our case, the autonomic nervous system, and trying to come out with some explanation, mechanistic explanation on how a particular molecule can serve in terms of blood pressure control and symptoms control. So atomoxetine is one of them. We used to have in the past some other medication that we gave to patients, like yohimbine, for example. It's no longer in the market. So this is a process that we're continuing doing in different institutions, and now with the Autonomic Consortium, sometimes it's getting easier to start this clinical trial and start the recruitment in multiple centers. Okay? And
I've got a live stream question. 2, 3, 4 live stream questions here. One is it worth getting a second opinion? Great question. I would say in my clinic, I usually are seeing patients that have a fifth opinion. And that's just the nature of where I work. I work in an academic medical center where patients have seen a primary care doctor, a neurologist, another neurologist, a friend of a neurologist, or cardiologist, and then they come to me. So I think, we're trying to change this, obviously. We need to do a better job about educating clinicians all across the United States and America and Trinidad, Tobago, and Ireland about MSA, and we need to do a better job of it. But I do think that when it comes to disorders that are rare, and when it comes to disorders that are neurodegenerative, meaning that over time it's going to change and it's going to get worse, I do think it's worth seeking out expert opinions about treating these symptoms. I think autonomic dysfunction in particular is a very complicated and difficult set of symptoms to treat. And I think it's worth going to see a person who's an expert in autonomic disorder if you have autonomic symptoms. Just like I think that if you have motor symptoms that are related to Parkinson's disease or MSA, I think it's worth getting an opinion for someone that's seen a lot of those diseases. So I do think it's worth getting a second or third or fourth or fifth opinion, depending on where you are in this process, to partner with you in getting you the best care possible. I have a set of questions about sleep. First, about treating sleep problems. For instance, what about sleep apnea? What about CPAP? What about BiPAP? What do we use? I would say that what we do in our center, and I think this is not atypical. This is the way a lot of us neurologists and medicine doctors work, is we really partner with our folks who are sleep experts. And so it may be that you have more than one thing going on. You may have stridor. You may have sleep apnea as well. You may have central apnea, where your brain just forgets to tell your diaphragm to move at night. So I think it's important that if you have symptoms that could be related to those things, that you get to see an expert sleep doctor, and that your decision on whether or not you decide CPAP or BiPAP or any other therapy for your sleep would be directed not just because of the disease, but because of the symptom that you're trying to treat. And so I think the answer to those questions are, it really depends on what symptom that you're trying to treat, whether or not you need CPAP or BiPAP or something else. Good. I've talked too much. You're next. Yeah. Yeah, sure. Anyone.
Okay. So this is a very interesting question. Can infection cause fluctuations? It means some blood pressure, right? So, and the answer is yes. So when you have autonomic failure and orthostatic hypotension, we put a medication, and sometimes, you can deal with some of the symptoms. The symptoms are never going to disappear. But when you get an infection is when we see much lower values of blood pressure. And people sometimes tend to pass out and fall. So, and that's one of the reasons why we sometimes have patients in the hospital, because they're fighting an infection, particularly urinary tract infection, and there is a significant descompensation not only in symptoms but in blood pressure control, and that is when we have to come out with combination of medication and then to control that. Should I keep going? Do you want to take
I have two questions about blood pressures, and is there a specific blood pressure medicine level that you don't want to go below, and what targets you should aim for? I'm looking for something more specific, and then one was kind of more of a how is your blood pressure medicines change, or will they stop working over time? So as far as a blood pressure number, obviously going below 60 is and most everyone is going to make them feel like they're going to faint or pass out. Some people amazingly can tolerate lower blood pressures than others and still be cognitively somewhat functional, although if you really probably pushed them, you'd find that they're probably not as functional as they think they are, just like doctors who try to stay up too long. So really, we tend to go by how you feel, and one of the markers we use is basically how long can you stand up before you start feeling like your vision's going, before you feel like your legs start getting shaky. Some people feel short of breath when their blood pressure drops. Some people feel weak all over when their blood pressure drops. So a lot of it is kind of the way you feel. If the way you feel tends to correlate with a specific number, then obviously that number for you is how low you don't want to go, and then you want to have a way that you can sit down or lie down right away. And then as far as getting your blood pressure, getting your blood pressure cuff to send data to the phone and to a database, I don't know if they have that yet. They have it for glucose meters, but we don't have it yet. Generally what we end up doing is we have a portal at Vanderbilt, and a lot of doctors have kind of My Health portals where it allows the patients to attach or email their blood pressure logs to us, and then that way we can look at it and then make adjustments to their medicines based on what data they send us. So or we can do the old-fashioned snail mail or faxing, so that's one of the things that we do.
This is another question. Does it make a difference if you drink cold water versus room temperature water to increase your standing blood pressure? That's a very interesting question, because when James Jordan at Vanderbilt and David Robertson discovered this effect of water based on the observation of a patient, then they start a series of a study, because when you observe something, then you want to go very specific in terms of your observation. That's part of being a scientist. So I remember the literature that they try everything. They try cold water, they try room temperature water, they try water plus salt, they try 480 mLs per in terms of the amount of water, 16 ounces. They went to 16 ounces, and the message that we usually give to patients is it doesn't matter if it's cold water or it doesn't matter if it's room temperature water, it has to be tap water. And you have to be drinking it as fast as you can. And the effect usually peaks about 30 minutes, and then it goes away. And it's a very rescue method when you have, these significant symptoms. You drink it as fast as you can. It will increase your blood pressure immediately. And a lot of our patients, for example, those who still can drive, just keep a bottle of water next to them. So it doesn't matter, the temperature doesn't matter, really just, being tap water, and then drink it as fast as you can, and it's 16 ounces of water that we usually recommend.
All right, I have about 6 cards here that circling around a similar issue, so I'll try and summarize all of them. And again, if you have any persistent questions that you don't feel like got answered properly at the end of this session, just come and talk to us, and we're here for you. The main symptom questions that a lot of people are asking about are these kind of non-dizziness symptoms related to MSA. And let me just give you an example. Someone asked about severe headaches and coat hanger pain. Other person asked about reading problems. Another person asked about vision changes. Another person asked about the heart beating quickly when you stand up. So the simple answer is that, and I say this to my patients, that you don't just have to be dizzy to have orthostatic hypotension. It can present and manifest with a lot of other things other than dizziness. And I think the key point is that kind of time blocking when your symptom happens to what you're doing is very useful for a physician, because they're going to be able to work with you and say, you know what, that type of coat hanger pain that you're experiencing, that's a really orthostatic hypertension type symptom. We're going to really target that orthostatic hypertension issue to try and improve that. Or those symptoms of like when you're kind of seeing double or feeling ditzy, that was another comment someone said, are maybe related to blood pressure drops or other symptoms. So I think, yes, all of those symptoms can happen in MSA. Yes, they can be related to orthostatic hypotension, and yes, they could be related to non-orthostatic hypotension, but really working with your doctor for those is important. Another set of questions I've got 3 questions now on driving. This is a really big one. Most difficult discussion I have with my patients, especially male patients, is driving. Driving is the last vestige of independence. When you tell a patient, you know what, no need to drive anymore, never had a patient say, great, thanks, awesome. It's always a tough conversation. But here's the reality, is that driving is not only about safety for you, but it's safety for others. So what we usually recommend is if a person's got slowed responses, slowed reaction time, problems with thinking clearly, we do recommend that folks do consider carefully driving. And what we do in our place is we send folks to an independent driving evaluation that's done by some of our colleagues in occupational therapy area. And why we like that is because it's objective. The patient doesn't have to think that I'm being mean to them by telling them they can't drive. We get some hard data on how they're doing with their driving, their ability to stop quickly, navigate turns. And it really is about safety for you and those around you. So, yes, it's very important to address driving, and the sooner you address it, the better. And the sooner you can really kind of think through the ramifications of not driving, and it's a tough process. It's really hard to stop driving. I think it's going to be the easier for you in the transition. You got one more each, and then I'll close up.
So I don't know if I can get I have still a lot of questions here. Some of these people just have to come up, I think, after the break. But one question that I thought was worthwhile covering, because I was being somewhat sexist, and they called me on it, was you discussed male impotence treatment, but what about female impotence treatment? Can Viagra work, stimulating creams, possible treatments in the pipeline? So yes, Viagra can work for women. So if you remember your basic anatomy, getting blood flow to the clitoris is important for orgasm, just like getting blood flow to the penis. However, the same caveats apply, because just like Viagra and all those medicines will drop your blood pressure if you're a man, they still drop your blood pressure if you're a woman. So same problem. And talking to a urologist or a gynecologist, to sort out, is the problem, all MSA versus, the other factor women end up running into, the same as men, is some of it hormonal, will estrogen creams help, things like that can be important. And then the other question that I will quickly answer is there's several questions about muscle relaxants and pain. And I think that goes back to Dr. Claassen's comment about correctly diagnosing where the pain and this and this muscle stiffness is coming from. If the muscle stiffness is coming from a Parkinsonism, a muscle relaxant is not going to be as helpful. But some patients with MSA do get what we call spasticity or tightening of the muscle from an upper motor neuron problem, and those patients can get some relief. So talking to your neurologist, talking to your doctor, and having them carefully examine you to determine what the source is, I think, to better figure out how to fix your pain in the best way that makes sense is probably the right answer.
I'm just going to address one more question, and I will let you close the session. And I think this question is very important. How do we get atomoxetine now? So the data that I show is, it's very encouraging. But that doesn't mean that you should go to your doctor and say, well, just prescribe atomoxetine. We need to still do a lot of research. We need to know whether the effect holds over time, whether it improves symptoms over time, what is the safety, particularly in the population of multisystem atrophy. So the example I gave with Mr. Harris was, it was difficult to control his blood pressure with the current medication that we have, and that's something that we did for him in terms of trying to accomplish his goal. But I think that there is more research that we need to do. Atomoxetine is available not over the counter, but it's available right now as a prescription for attention deficit disorder. Insurance company usually doesn't pay for that because there is no indication. So we need to still work a lot on getting there. Okay.
Great. So this has been a fantastic session. I think I personally have learned a lot from listening to these talks. I do want to do a couple things. First, I want to give you an update on our live feed. We've got some people from Belgium. Welcome, Belgium. Hope you're enjoying your chocolate, because that's about the time there. And we have a lot of representation from New Jersey, Florida, and Texas. So thank you to all the folks from New Jersey, Florida, and Texas for showing up. And then the last big thanks is for Jerry Krause, who's watching from North Carolina. Thank you. Let's give a big hand to Jerry. She's done a lot of volunteer work for the MSA Coalition. And yes?
I was going to tell you, we've had 2,190 people reach by live stream.
2,190 people reach. That's fantastic. Great work. So that's the end of this session. Come up and talk to us. If we didn't get your questions, it's not because they were bad questions, just because of time. But I really appreciate you coming today. Thank you to everyone online, and we'll see you after lunch.
Before you break, thank you to these terrific speakers and their time and compassion and care for this community. Thank you. You have about an hour and a half. Relax, get some lunch. I believe things are set up out there. We are... Please visit the exhibits one last time. Please make your way through. And after everyone's settled down with their plates, we do have a very brief business report so that you have an update on what's happening with the coalition. We think, we want to keep you informed.
Didn't want to ever go there and give them